Hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist and vice chair of academic affairs at the City of Hope Comprehensive Cancer Center in Los Angeles. There are always multiple challenges facing oncologists, and today we discuss two of them that really stand out for 2026: threats to federal funding for cancer research and the persistent problem of drug shortages. I'm thrilled to welcome Dr. Jason Westin, who believes that one way to meet these challenges is to get oncologists more involved in advocacy, and he'll share some strategies to help us meet this moment in oncology. Dr. Westin is a professor in the Department of Lymphoma and Myeloma at the University of Texas MD Anderson Cancer Center, but he actually wears a lot of hats within ASCO. He's a member of the board of directors and has also previously served as chair of ASCO's Government Relations Committee. He's also one of the inaugural members of ASCO's Political Action Committee, or PAC. He's testified before Congress about drug shortages and many other issues. Dr. Westin, I'm really excited to have you on the podcast today and dive into some of these elements that will really impact our community in 2026. Thanks so much for joining us today.
Thank you for having me.
You've had such a range of experiences. I already alluded to you testifying before Congress. You've actually run for office before. You wear so many different hats. I'm used to checking my PubMed every other day and seeing a new paper out from you and your group, and you publish in the New England Journal on practice setting standards and the diseases that you treat. But you've also done all this work in the domain of advocacy. I can't imagine that balancing that is easy. What sort of motivated you on the advocacy front?
Advocacy to me is another way to apply our skills and help more people than just those that you're sitting across from at the time. Clinical research, of course, is a tool to try and take what we know and apply it more broadly to people that you'll never meet. And advocacy, I think, can do the same thing, where you can have a conversation with a lawmaker, you can advocate for a position, and that hopefully will help thousands or maybe even more people down the road who you never get to directly interact with. And so I think it's a force multiplier in the same way that research can be. And so I think advocacy is a wonderful part of how doctors care for our patients. And it's something that is often difficult to know where to start. But once people get into advocacy, they can see that the power, the rewarding nature of it is attractive. And most people, once they get going, continue with that through the rest of their career.
So I'll ask you to expand on that a little bit. We have a lot of our younger ASCO members listening to this podcast, folks that are just starting out their careers in clinical practice or academia. Where does that journey begin? How do you get to the point that you're testifying in front of Congress and taking on these bigger sort of stances for the oncology community?
Yeah, with anything in medicine and in our careers, you have to start somewhere. And often you start with baby steps before you get in front of a panel of senators or other high profile engagement opportunities. But often the first setting for junior colleagues to be engaged is doing things, we call them Hill days, but basically being involved in kind of low stakes meetings where you're with a group of peers, some of whom have done this multiple times before, and can get engaged talking to members of representatives' offices, and doing so in a way where it's a natural conversation, that you're telling a story about a patient in your clinic, or that you're telling a personal experience from a policy that impacted your ability to deliver optimal care. It sounds stressful, but once you're doing it, it's not stressful. It's actually kind of fun. And it's a way that you can get comfort and skill with a group of peers who are there and able to help you. And ASCO has a number of ways to do that, both at the federal level. There's the Hill Day, where we each April have several hundred ASCO members travel to Capitol Hill. There's also state engagement that can be done, so-called visiting at home, when representatives from U.S. Congress or from state legislators are back in district. You can meet with your own representatives on behalf of yourself, on behalf of your organization, and advocate for policies in a way that can be beneficial to your patients. But those initial meetings that are in the office, often they're low stakes because you could be meeting not with the representative, but with their staff. And that staff sometimes is as young or even younger than our junior colleagues. These sometimes can be people in their 20s, but they're often extremely knowledgeable, extremely approachable, and are used to dealing with people who are new to advocacy, but they actually help make decisions within the office. So it's not a waste of time. It's actually a super useful way to engage. So it's that first step of anything in life. The activation energy is always high to do something new, But I'd encourage people who are listening to this podcast already having some level of interest about it to explore ways that they could engage more.
I have to tell you, I'm going to riff on what you just said for a second. ASCO couldn't make it any easier, I think, for folks to participate and get involved. So if you're listening to this and scratching your head and thinking, well, where do I begin? How do I actually sign on for that meeting with a local representative? Go to the ASCO Act Network website, and I'll actually talk to our producer, Geraldine, to make sure we've got a link to that somewhere associated with this podcast after it's published, Jason. But I actually keep that on my browser, and it's super easy. I check in there every now and then and see if there's any new policy or legislation that ASCO, is sort of taking a stance on. And it gives me some fodder for conversation with my local representatives too. I mean, it's just an awesome, awesome vehicle. I'm going to segue right from there, right to the issues. So you and I are both at academic centers. I think that this is something that really pervades academia and enters into implications for general clinical practice. There's been this, massive sort of proposal for decreased funding to the NCI and to the NIH and so forth. Tell us what ASCO is doing in that regard, and tell us perhaps how our community can help.
We live in interesting times, and I think that may be an understatement times 100, but obviously investments in research are things that when you're at an academic center, you see and feel that as part of your daily life. Members of Congress need to be reminded of that because there's a lot of other competing interests out there besides investing in the future through research. And being an elected representative is a hard job. That is something where you have to make difficult choices to support this, and that may mean not supporting that. And there's lots of good things where our tax dollars could be spent. And so I'm sympathetic to the idea that there's not unlimited resources. However, ASCO has done an excellent job, and ASCO members have led the charge on this, of stating what research does. What is the benefit of research, and therefore why should this matter to elected representatives, to their staff, and to those people that they're elected to serve? And ASCO has led with a targeted campaign to basically have that message be conveyed at every opportunity to elected representatives. And each year on Hill Day, one of the asks that we have is to continue to support research. The NCI, NIH, ARPA-H, these are things that are always in the asks to make sure that there's appropriate funding, but effectively playing offense by saying, it's not just a number on a sheet of paper. This is what it means to patients. This is what it means to potentially your loved ones in the future. If you are in the opposite situation where you're not on the legislative side, but you're in the office receiving a diagnosis or receiving a difficult piece of news, we only have the tools we have now because of research. And each breakthrough has been years in the making and countless hours spent funded through the engine of innovation, clinical research and translational research. And so ASCO continues to beat that drum. You mentioned earlier the ACT network. Just to bring that back again, is a very useful, very easy tool to communicate to your elected representatives. When you sign up on the ASCO ACT website, you get emails periodically, not too much, but periodically get emails of, this is a way you can engage with your lawmakers to speak up for this. And as you said, Monty, they make it as easy as possible. You click the button, you type in your address so that it figures out who your elected representatives are, and then it will send a letter on your behalf after like 5 clicks to say, I want you to support research. I want you to vote for this particular thing, which is of interest to ASCO and by definition to members of ASCO. And so the ACT network is a way that people listening can engage without having to spend hours and significant time, but just a few clicks can send that letter to Representative Congress. And the question could be is, does that matter? Does contacting your senator or your elected representative do anything? If all they're hearing is somebody else making a different argument, and they're hearing over and over again from people that want investments in AI or investments in something else besides cancer research, whatever it is, they may think that there's a ground shift that people want dollars to be spent over here as opposed to at the NIH or NCI or in federally funded research. It is important to continue to express the need for federal funding for our research. And so it really is important for folks to engage.
100%. One of the things that I think is not often obvious to a lot of our listeners is where the support for clinical trials come from. You've obviously done the whole gamut of studies at SFI. We have our pharmaceutical company sponsored studies, which are in a particular bucket. But I would say that there's a very important and critical subset of studies that are actually government funded, right? NCI funded clinical trials. If you don't mind just explaining to our audience the critical nature of the work that's being done in those types of studies. And if you can, maybe compare and contrast the studies that are done in that bucket versus perhaps the pharmaceutical bucket.
Both are critical, and we're privileged that we have pharma studies that are sponsored and federally funded clinical research. And I think that part of a healthy ecosystem for us to develop new breakthroughs has a need for both. The pharma sponsored studies are done through the lens of trying to get an approval for an agent that's of interest so that the pharma company can then turn around and use that outside of a clinical trial after an FDA approval. And so those studies are often done through the lens of getting over the finish line by showing some superiority over an existing treatment or in a new patient population. But they're done through that lens of kind of the broadest population and sometimes relatively narrow endpoints, but to get the approval so that then the drug can be widely utilized. Clinical trials done through cooperative groups are sometimes done to try and optimize that or to try and look at comparative things that may not be as attractive to pharma studies, not necessarily going for that initial approval, but the fine tuning or the looking at health outcomes or looking at ensuring that we do studies in represented populations that may not be as well identified on the pharma sponsored trials, but basically filling out the gaps in the knowledge that we didn't gain from the initial phase 3 trial that led to the approval. And so both are critical, but if we only do pharma sponsored trials, if we don't fund federally supported research and that dries up, the fear I have and many others have are that we're going to be lacking a lot of knowledge about the best ways to use these great new therapies, these new immune therapies, or in my team, we do a lot of clinical trials on CAR T cell therapies. If we don't have federally funded research to do the important clinical studies, we'll be in the dark about the best ways to use these drugs. And that's going to be a terrible shame. And so we really do need to continue to support federal research.
There are no softball questions on this podcast, but I think everybody would be hard pressed to think that you and I would come on here and say, well, no, we don't need as much money for clinical trial and NCI funding and so forth. But I think a really challenging issue to tackle, and this is something we thought to ask you ahead of the podcast, is what to do about the general climate of, whether it's academic research or clinical practice here, that seems to be getting some of our colleagues thinking about moving elsewhere. I've actually talked to a couple of folks who are picking up and moving to Europe for a variety of considerations, other continents, frankly. The US has always been a leader when it comes to oncology research, and one might argue research in general. Some have the mindset these days that we're losing that footing a little bit. What's your perspective? Are you concerned about some of the trends that you're seeing? What does your crystal ball tell you?
I'm highly concerned about this. I think, as you said, the US has been a leader for a long time, but it wasn't always. This is not something that's preordained, that the world leading clinical research and translational research will always be done in the United States. That is something that has been developed as an ecosystem, as an engine for innovation and for job development, new technology development since World War II. That's something that through intentional investments in research was developed at the best and brightest around the world. If they could choose to go anywhere, you wanted them to come to work at universities and academic places within the United States. And I think, as you said, that's at risk if you begin to dry up the investment in research, or if you begin to have less focus on being engaged in research in a way that is forward thinking, not just kind of maintaining what we do now or only looking at having private, for profit sponsored research. But if you don't have the investment in the basic science research and the translational research and the forward thinking part of it, the fear is that we lose the advantage and that other countries will say thank you very much and be happy to invest in ways to their advantage. And I think, as you mentioned, there are people that are beginning to look elsewhere. I don't think that it's likely that a significant population of researchers in the US who are established and have careers and families, and I don't think that we're going to see a mass exodus of folks. I think the real risk to me is that the younger up and coming people in undergraduate or in graduate school or in medical school and are the future superstars, that they could either choose to go into a different field. So they decide not to go into what could be the latest breakthroughs for cancer patients, but could be doing something in AI or something in a different field that could be attractive to them because of less uncertainty about funding streams. Or they could take that job offer if it's in a different country. And I think that's the concern, is it may not be a 2026 problem, but it could be a 2036 or a 2046 problem that we reap what we sow if we don't invest in the future.
Indeed, indeed. I had the pleasure of reviewing abstracts for some of our big international meetings, as I'm sure you've done in the past too. I see this trend where, as before, we would see the preponderance of large phase 3 clinical trials and practice setting studies being done here in the US. I'm seeing this emergence of China, of other countries outside of the US really taking lead on these things. And it certainly concerns me. If I had to sort of gauge this particular issue, it's at the top of my list in terms of what I'm concerned about. But I also wanted to ask you, Jason, in terms of the issues that are looming over oncology from an advocacy perspective, what else really sort of keeps you up at night?
I'm quite concerned about the drug shortages. I think that's something that is a surprisingly evergreen problem. This is something that is on its face illogical, that we're talking about the greatest engine for research in the world being the United States, and the investment that we've made in drug development and the breakthroughs that happen for patients all around the world. Many of them happen in the United States. And yet we don't necessarily have access to drugs from the 1970s or 1980s that are cheap, generic, sterile, injectable drugs. This is the cisplatins and the vincristines and the fludarabine type medications, which are not the sexy ones that you see the ads in the magazine or on TV at night. These are the backbone drugs for many of our curative intent regimens for pediatrics and for heme malignancies and many solid tumors. And the fact that that's continuing to be an issue is, in my opinion, a failure to address the root causes. And those are going to require legislative solutions. The root causes here are basically a race to the bottom, where the economics to invest in quality manufacturing really haven't been prioritized. And so it's a race to the cheapest price, which often means you undercut your competitor. And when you don't have the money to invest in good manufacturing processes, the factory breaks down, there's no alternative, you go into shortage. And this is something that's been going on for a couple of decades. And I don't think there's an end in sight until we get a serious solution proposed by our elected officials. That is something that bothers me in the ways where we know what we should be doing for our patients, but if we don't have the drugs, we're left to be creative in ways we shouldn't have to do to figure out a plan B when we've got curative intent therapies. And I think that's a real shame. There's obviously a lot of other things that are concerning related to oncology, but something that I have personally had experience with when I wanted to give a patient a CAR T cell and we don't have a supply of fludarabine, which is a trivial drug from decades ago in terms of the technology investments in genetically modified T cells, to not then have access to a drug that should be pennies on the dollar and available at any time you want it, is almost like the Air Force investing in building the latest stealth bomber, but then forgetting to get the jet fuel in a way that they can't use it because they don't have the tools that they need. And so I think that's something that we do need to have comprehensive solutions from our elected officials.
Brilliantly stated. I like that analogy a lot. Let's get into the weeds for a second here. What would that proposal to Congress look like? What are we trying to put in front of them to help alleviate the drug shortages?
We could spend a couple hours, and I know podcasts usually are not set up to do that. And so I won't go through every part. I will direct you that there have been a couple of recent publications from ASCO specifically detailing solutions. And there was a recent white paper from the Senate Finance Committee that went through some legislative solutions being explored. So Dr. Graylow, ASCO CMO, and I recently had a publication in JCOOP detailing some solutions more in that white paper from the Senate Finance. And then there's a working group actually going through ASCO's Health Policy Committee, putting together a more detailed proposal that will be published probably around the end of 2026. Very briefly, what needs to happen is for government contracts for purchasing these drugs, there needs to be an outlay for quality, meaning that if you have a manufacturing facility that is able to deliver product on time, reliably, you get a bonus in terms of your contract. And that changes the model to prioritize the quality component of manufacturing. Without that, there's no reason to invest in maintaining your machine or upgrading the technology you have in your manufacturing plant. And so you have bottlenecks emerge because these drugs are cheap and there's not a profit margin. So you get one factory that makes this key drug. And if that factory hasn't had an upgrade in their machines in 20 years and that machine conks out and it takes 6 months for repair or replacement, that is an opportunity for that drug to go into shortage and causes a mad dash for big hospitals to purchase the drug that's available, leaving disparities to get amplified. It's a nightmare when those things happen, and they happen all the time. There's usually dozens, if not hundreds of drugs in shortage at any given time. And this has been going on for decades. This is something that we do need large system-wide fixes, and that investment in quality, I think, will be a key part.
Yeah, brilliantly said. And I'll make sure that we actually include those articles on the tagline for this podcast as well. I'll talk to our producer about that as well. I'm really glad you mentioned the time in your last comment there, because I felt like we just started. But in fact, I think we're right at our close here, Jason, unfortunately. So I could have gone on for a couple more hours with you. I really want to thank you for these absolutely terrific insights. And thank you for all your advocacy on behalf of ASCO and oncologists at large.
Thank you so much for having me. I've enjoyed it.
Thanks a lot. And many thanks to our listeners, too. You can find more information about ASCO's advocacy agenda and activities at asco.org. Finally, if you value the insights that you heard today on the ASCO Daily News Podcast, please rate, review, and subscribe wherever you get your podcasts. Thanks so much.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.